So this is his 20th appearance on this webinar series, breaking all records. We always get great feedback from his lectures, so we just keep on bringing him back. He's the director of the Resnik Implant Institute, which is the premier implant training program in the country. He's the author of 2 textbooks, the 4th edition of Mish's Contemporary Implant Dentistry, and also Avoiding Complications in Implant Dentistry. He's a frequent contributor to Chairside Magazine, and his topic today is one that generates lots of questions. So he's here today to answer. So he's going to continue his occlusion series with understanding vertical dimension. Dr. Randy Resnik, it's all yours. Take it away.
Okay, thank you, Neil. We made it through 5 these occlusion webinars, and I'd tell you, I wanted to thank Neil because he had the foresight to really ask, and basically he said, we need this in our field. And this is such a confusing subject. And hopefully through these 5 different seminars, you've been able to take something back to your practice. This last one is, I put it last because it's the most confusing. So vertical dimension is something that is very misunderstood. And with today's webinar, hopefully at the end, you'll be able to take some pearls back to your office so that you can go ahead and implement some of these protocols and classifications into your practice. So first of all, if we look at the literature, there's an abundance of literature on vertical dimension. The problem is there's very few well-controlled and randomized studies. I usually, as you know, anything that we teach, I always try to go over systemic reviews and meta-analysis. In most occlusion and vertical dimension studies, they just don't exist. Therefore, this is one of the most debated and very controversial topics in dentistry that basically very few people agree on. So what I'm going to do today, my objective is, first of all, to teach you exactly what is vertical dimension, how to diagnose a non-ideal vertical dimension, and be able to tell, can you alter this vertical dimension, this patient? And if we are going to alter it, how do we alter it? And then at the very end, I'm going to summarize and give you a protocol that you can take back to your office when you're evaluating these cases. So let's get right into understanding vertical dimension definitions. Now, this is all from the Journal of Prosthetic Dentistry, Glossary of Prosthetic Terms. So if we look at vertical dimension, what actually is it? It's a measured distance between 2 reference points. That's all it is. Very simple. However, we have vertical dimension occlusion. We have this vertical dimension when the maxilla and the mandible are in maximum cuspation, basically centric. So that is vertical dimension of occlusion. Then we have at rest, when the mandible's at rest and the muscles are at rest, and that is another type of vertical dimension. Some people call it the physiologic rest position. Other people call it the interocclusal rest position. You might hear freeway space. So what actually is freeway space? Some people call it the interocclusal rest space. It's basically the difference between vertical dimension of occlusion and vertical dimension of rest. So to determine freeway space, you have to determine the VDO and the VDR. So if we look at determining freeway space, because we use this a lot in prosthetic dentistry, for tooth position, vertical dimension, and other maxillomandibular relations, we have to determine where is VDR, where is VDO, and then that gives us our freeway space. Now, when we look at vertical dimension, there is a new or relatively newer type or definition for vertical dimension of speech. And this is, we use speech sounds, phonetic sounds to determine vertical dimension, but now there's actually a definition in the prosthetic glossary where it's a vertical position when of the teeth when they're in close proximity during speaking, different sounds. And we'll go over some of those sounds here in a minute. Now, how do we determine where these reference points are, or how do we determine how to measure it? Usually what we do is we select one reference point on the maxilla, one on the mandible. Most common is the tip of the nose and the chin. Now, what you have to understand is these points are very arbitrary. You can pick them wherever you want. These are just the most common areas. But sometimes people talk about numerical measurements of vertical dimension. There really isn't a numerical measurement because of the arbitrary selection of these points. So just so you know, you can pick it anywhere, but use that as your baseline when you're determining these different types of vertical dimension. So why is vertical dimension so important in implant dentistry? Well, first of all, if we have full dentition, no loss of vertical dimension, our vertical maintains function, aesthetics, occlusion, everything prosthetically, stability, longevity. It controls the health of the TMJ and it maintains muscle balance. So we need ideal vertical dimension for all that to be normal and ideal. However, when we start losing vertical dimension, such as we lose posterior support or we get flared, the anterior teeth start to flare and the vertical dimension becomes decreased, now all those ideal factors I talked about become compromised. And then when we take out teeth, we lose all of our vertical dimension, especially if we don't have pre-extraction records. So this is very important that we know where the ideal vertical dimension is, or we try to maintain what the patient had previously if we're taking all the teeth out. So what are the factors that affect vertical dimension? The main one is the teeth, especially for vertical dimension of occlusion. Then we have muscles, which is very important for the vertical dimension of rest. And then we have compensatory issues where teeth adapt, they move. So we get super eruption, not only of the teeth, but also of the alveolus. And that comes into play. So there's a lot of factors that come into play with vertical dimension. So how do we evaluate vertical dimension? What's the best way to evaluate it? First thing is we look at the patient and we evaluate the patient clinically. Is their vertical dimension ideal? Does it need to be open or closed? Then another question, if it does, can we alter it? And then if we do alter it, how much do we alter it? Whether increasing it or decreasing it. So these are all questions that we have to look at. And you should, when you look at a patient, especially if you're going to modify or reestablish their vertical dimension, these factors need to be taken into consideration. So the best way to evaluate vertical dimension is have pre-extraction records, even if it's not ideal. If it is ideal, well, we maintain it. But at least we have a baseline that we can go over if we change it, whether we open it or we close it. There's other ways of assessing or evaluating vertical dimension. And I have 5 different ways right here, and we'll go over these one at a time. The first is freeway space, just what I talked about earlier. It's a vertical dimension of rest minus the vertical dimension of occlusion equals the freeway space. So what is so big about freeway space? Well, basically, this is used in prosthetic dentistry to evaluate and to position the teeth and for our maxillomandibular relations. Numerous studies have evaluated what is the ideal freeway space. And most studies show about 3 millimeters, approximately 3 millimeters. Other studies will have a range, the most common being approximately 2 to 7 millimeters, but usually the freeway space, meaning when you determine the VDR and the VDO, 3 millimeters is ideal. So how do we determine the VDR? Well, this is the difficult ones because the VDR is muscle related. So what we have to do is determine where this patient is at rest and evaluate that vertical dimension at rest. There are techniques where you have the patient just relax and bring their lips together and just basically see if the elevator muscles of the mandible can just relax. And then we measure that position. Other techniques, instruct the patient to lick their lips, swallow, and just relax their jaw. So as you can see, VDR is a lot more difficult to determine because there is not actually one point and it can be a zone. And we'll talk about that at the very end. There's other options. The M sound is used a lot, where you hum the M sound, and the theory is when patients utilize the M sound, it relaxes their lips and their jaw muscles, and this puts them into this state of relaxation, and this gives us our measurement of vertical dimension of rest. The easy one is vertical dimension occlusion. All we do is we have the patient bite into maximum intercuspation. So basically, we have them bite, we have a basically eccentric stop, and it's very, very easy to measure. So vertical dimension of occlusion is a lot easier to determine than vertical dimension of rest. Another topic or another option is with phonetics, and this came about in the 30s and in the early 20th century, using different sounds to determine where the vertical dimension is. So if we look at the most common one used in dentistry, in just prosthetic dentistry, it's Silverman's speaking space, closest speaking space. Basically, you're going to use an S sound or a sibilant sound. And this goes back to his article in 1951, where he evaluated this, and he said this is a great way to determine where the vertical dimension should be. However, there has to be a space. So that space should be approximately 1 millimeter. If there's no space, that's a non-ideal vertical dimension. Or if there's too much space, then that is a non-ideal vertical dimension. So the sibilant sounds, the S sounds, the Silverman sounds is one of the earliest ones, and probably one of the more common ones that we use today. Another is the F and the V sound. Earl Pound was first to talk about this. And basically, what you do is any of the F or the V sounds, you evaluate the patient's maxillary incisor tips to the approximation of the mandibular lip. Ideally, they should just lightly touch. So if the vertical dimension is ideal, when speaking the F or the V sounds, those maxillary incisors should just lightly touch. If there's no contact, the patient's too open. If there's excessive contact, then they're going to be too close. So this is just another way of evaluating it. A third way is with facial measurements. Now, how do facial measurements, how did it even come into play here? It all started with Leonardo da Vinci back in the 1500s. He was the first one to evaluate the face, the proportions of the face, and he did the first writings on this. This led to basically a foundation for future researchers to take this information and come up with different ways of estimating vertical dimension. If you look at the article on the left, McGee's article from 1947 in the ADA journal, and up to right now, here's one from 2020 talking about how you can use facial measurements. So it is something that has been around a long time. There's different types, and what I'm going to go over is just a couple of different examples here for you. The first one, and one of the more common ones, is the Willis method. Basically, you look at the upper facial height and the lower facial height, and they should equal each other. And that tells you how ideal the VDO is. You go from the pupil of the eyes to the corner of the mouth, and then the anterior nasal spine to the lower border of the mandible. So the Willis method it's an objective technique, and it's one of the more common ones that have been used for many years. In fact, a lot of you might even have one of these Willis bite gauges, which a lot of people use to help in determining the measurements and the vertical dimension of occlusion. There's other types, and in our textbook, I probably have about 30 different facial measurements that you can use. This is just another one that's a lot more common, where you measure the distance from the chin and the nose, and that should equal from the hairline of the eyebrows, the height of the ear, and the eyebrows to the bottom of the nose. So basically, these dimensions, they're all equal, 1/3 of the face, and this is just another use of facial measurements. Then there are some that are really interesting. And if you look at some of the studies on them, they're very, very close. In our prosthetic boot camp course, we have all the doctors go through these. So they actually measure each other, and you'd be surprised at how close these are. This is one that just looks at the height of the tip of the thumb to the tip of the index finger to other measurements on the face, and it coordinates to those thirds that I was talking about. So again, these are facial measurements. Some of these are objective, and like I said, they are very close, and they've been in the literature for a long time. A fourth way of evaluating is clinical examination, looking at the patient. So we can evaluate the patient when they're speaking. We can evaluate the patient when they're eccentric. So we obviously know on the image on the upper right, this patient's contacting the maxillary teeth on the mandibular ridge. We know this patient has a vertical issue. Or we know the patient on the lower has a very poor occlusal plane and table, and we know that most likely the vertical is way too open on this. So we can use clinical examinations. However, these are more subjective. Even though we can evaluate it, the first area that you want to evaluate when you look at the face is in profile. So look at the lower 1/3 of the face. When you see the chin getting very close to the nose and more of a sunken in look, we know that we've lost vertical. So there's an aesthetic part of this in evaluating the vertical dimension. Lip fullness. We know someone who has a collapsed vertical, they're going to have thinning of the lips. Sometimes you won't even see the lips. Or if a patient has excessive vertical, then they're not going to be able to actually even get their lips together because their vertical is so open that they have to strain their lip muscles just to get them to contact. So lips can be evaluated. Swallowing can be utilized. So a normal video, when the patient swallows, the teeth should lightly come into contact. If the teeth hit too soon, or too hard, then we know our vertical dimension is too high. If the patient may the teeth may not even contact, then we know the vertical dimension is too low. So swallowing can be utilized. And then a very subjective technique is to look at the prostheses. So we can look at the patient's existing prosthesis. Have they worn out the teeth? What is the wear pattern of the maxilla and the mandible? And this will give us kind of a possible thought that this patient may need to be open, but we have to use other methods, just not looking at the existing prosthesis. And then we have the most common, most utilized now is advanced technology, which I call, which can be CBCT scans. Now we can take a scan of a patient, take a dual scan of the patient, be able to remove their teeth, be able to reposition their vertical and or their bite very easily with these virtual articulators. So CBCT scans have really given us the opportunity to evaluate vertical dimension and also be able to modify it. Digital smile design is very commonly used. What is so significant about digital smile design? So we can take a patient's smile, evaluate the position of the teeth, and also take into consideration the soft tissue aesthetics of the patient. So evaluating how much we can open the patient, what that does, not only to the function, but also to the aesthetics of the patient. And then one of the more common newer types of technology is facial scanning, where we can take these facial scans of the patient and we can basically look at symmetry, those different proportions, evaluate the soft tissue, and utilize this information also in combination with CBCT scans to evaluate the patient's vertical and to modify it if necessary. So now that we know what vertical dimension is, let's talk about what is so wrong if the patient has a non-ideal vertical dimension. What's the problem with that? Well, first of all, if we have someone like this, a decreased collapse bite, decreased vertical dimension, where obviously it is when you see the maxillary teeth hitting the mandibular ridge, or where the chin, the lower 1/3 of the face is sunken in. If you look at some of the terms, we call it decreased vertical dimension. Some people will call it overclosed or loss of vertical dimension, collapse bite, vertical dimension. Basically, they all mean the same thing. The patient's vertical dimension is compromised and it's decreased. So what are some of the problems? You're going to have less biting force. The reason is those muscles are going to be overextended. They're not going to be able to allow you to bite with the force they had when they had their natural teeth. You're going to get overclosure. So the TMJ, you'll start to get disc problems or subluxate the TMJ out of the glenoid fossa. You'll start to get muscle pain. The muscles will start to lose tone of the muscles, and then the patient will start biting their cheeks. The lips will lose their fullness, so there's an aesthetic issue with that. The corners of the mouth will start to get a fungal infection, that's angular colitis. And then in some cases, if it's really severe, the patient can have impaired hearing, what's called Costin's syndrome. So these are all clinical signs of a decreased vertical dimension. How about if the patient is way too open? So they have an increased vertical dimension. Well, some of the other terms used, open vertical dimension, excessive vertical dimension, overextended, or excessive, as I said before. What are some of the clinical signs of this? Loss of freeway space. So the patient, when they speak, there is no space between the teeth, and it's going to be a problem pronouncing different words. So the speech and phonetic issues, the teeth will begin to click, whether it's a denture or zirconia or hybrid type of prostheses. Difficulty in closing their lips because they're so open, they can't get their lips together. Now, if they're opened within the physiologic range of motion of the actual elevator muscles of the mandible, they'll actually have an increased biting force. But if they're open above that physiologic level, now they're going to have a decreased biting force. So it could be either way with an increased vertical dimension. Either way, they're going to have muscle comfort. The face is going to look elongated, so there's going to be an aesthetic problem. And again, you're going to have possible TMJ complications. So how do we reestablish vertical dimension? What is the technique in doing this? Well, let's look at what the literature says. There's 3 schools of thought. One says you never alter it. The second says you alter it, but you allow the patient to adapt. And the third says just alter it. There's no limits on doing that. So let's first look at the first school of thought. You never alter a vertical dimension. What is the rationale? It is believed that vertical dimensional occlusion, with some articles out there, show that it never changes over time. Patients just basically adapt to it. And if you alter that stable position, what it does is it alters or it's detrimental to the physiology of the masticatory system. So basically, it throws everything into chaos. And this adaptability of patients comes into a question. So there's many in the literature says never to alter it. Now, what can happen? TMJ, as I said, hyperactivity of the muscles, muscle pain, but also thought is that if you open a patient that should not be altered, or there's not enough space, the patient will use those muscles to intrude the teeth. And basically, they want to return back to that original vertical dimension. So what ends up happening is you increase parafunction. And I do believe that is true. So you have to be careful with that. However, the rationale you never alter is impractical because we know patients come in all the time, significant attrition, and they do have loss of teeth, loss, collapse of bite that need to be altered. So, however, there are 3 different clinical factors that go into place when you should never alter a vertical dimension. Number one is significant pair function. So if you look at this patient, obviously they have masseter hypertrophy. You can look at their masseters. They have anagonial notching. So the patient with significant pair function like this, you don't want to alter their vertical dimension. Or if you do, you have to be very, very careful in incrementally doing it because they're going to want to go back to where they were. A second time that you never want to alter vertical dimension is with dental alveolar extrusion. And some people call this compensatory eruption, basically where the teeth erupt and also the alveolus. Now, why is that significant? Because basically the vertical dimension has never changed. If you look at the lower right photo, the posterior teeth, there's no wear or attrition on the teeth. It's all only in the anterior. That's because that whole anterior segment is super erupted. That's called dental alveolar extrusion. In those cases, these patients most likely won't be able to be open, and you're going to cause a lot of issues if you do. And the third is the most common that I see, hear it from the labs. Okay, doc, you placed implants. We're trying to fit in a prosthesis over this bar or attachments. There's not enough space. We have to open their vertical, just like that, or something like this, or another one like this. So what you want to do is before the implants are placed and before a bar is placed or the prosthesis placed, you want to determine if there is actual room to do that. So here is just two cases I'll show you of implants that were placed that could not be restored. That green line is where the osteoplasty should have been done. So bone should have been removed to give you restorative space for the final prosthesis. And here's another one. So again, the patient went through dental alveolar extrusion, but that wasn't recognized. The implants were placed too high. Now the restorative or the prosthetic doctor has a real issue in rehabilitating that patient. So that's the first. The second option is their school thought is to alter the VDO, but there is an adaptation period, whether you're increasing it or you're decreasing it. And that is why I have it as a yellow light, because it can be done, but you have to do it with certain protocols in place. So there's a ton of literature out there that basically says patients do adapt to alterations within reason of their vertical dimension. And they might get symptoms, but they're transitory, so they're not long-term. So if we do look at how much, a lot of the factor that you have to look at is how much are we actually increasing. So these articles talk about the greater the vertical dimension increase, the longer the adaptation period. And that makes sense. We also have to look at the type of prosthesis. So these are some literature discussing different adaptation periods with different types of prostheses. If it's an implant-supported prosthesis, we know that adaptation period is going to take a lot longer. Why? Because when we have natural teeth, we have proprioception. And it's a lot easier to do when we have proprioception. So the thought process here is when you're taking a patient's teeth out on both arches and you're reestablishing vertical, you have to allow that patient to adapt. Whereas if you're using natural teeth and maybe you're just increasing them with crown and bridge or composites or whatever, proprioception comes into play and it adapts a lot faster. Here's an article that talks about the aesthetic value of VDO increases. Small versus large. What I see a lot is when patients do come in and their VDO is way too increased, there'll be significant aesthetic issues. So there's this balance between function and also aesthetics you have to take into consideration when you're just saying, oh, okay, I'm going to open this patient's vertical. So you have to be very careful with that. The third is alter the VDO. There's no limits, and basically it's a green light. Now, I don't agree with this, but there are a lot of people who discuss this, talk about it, and unfortunately, I think the majority of some of these all-next cases, this is the path that they take. And what does that mean? Well, basically, you can alter it and there's no limits. What the thought process is, complications are minimal, patients will adapt in time. So the easiest way is the lab articulate it. They say, you know what, we need 3, 4, 5 millimeter increase. They just open the pin and restore the patient at that vertical. So as I said, there are a lot of articles out there supporting this. And here's one in particular: no need for incremental changes. Patient adapts to these changes. However, my thought on this is if you do get complications, they are significant. And to put yourself at less risk, you have to be very, very careful in following this third school of thought. When is it the most common time for this to happen? Well, look at a patient with attrition. Okay, well, they've worn down their teeth. Well, okay, we have to certainly open them up, or we need space for a prosthesis or force issues. And these are bona fide possibilities, but you have to evaluate the patient to see if they can adjust and maintain a reestablish vertical dimension. So with that being said, with those 3 schools of thought, our recommendation, what we teach is, yes, you can alter it, but you have to be cognizant of an adaptation period. There are patients that definitely need altered. So the first school of thought just doesn't come into play. And the third school of thought is dangerous in some situations. So how do we actually alter the VDO? Well, if you look at studies and clinical experience, I can tell you it's a lot easier with a fixed prosthesis. It's more ideal. It's patients adapt easier, I believe. Anytime you have a removable prosthesis, whether it's an overdenture or just a conventional prosthesis, patients are less compliant. It's harder to get used to it. It moves around. So first of all, fixed is a lot easier. I'm going to give you some examples on real fast. We don't have long to go into this, but I'll just give you some examples on how this is done. Say a patient comes in with existing conventional dentures. That's very easy. We use wax rims. We reestablish it. Maybe we make a temporary denture. We reestablish it in the definitive prosthesis. Very easy and simple. How about a patient who just has the anterior teeth? They have a partial. We can incrementally build up their posterior, evaluate this vertical, evaluate their jaw joint, make sure that they can accommodate it. Then we finalize that vertical, whatever we're doing, full mouth rehab, implants, or whatever. When we get cases like this, when we're going to edentulate, or this is a patient that this is probably one of the easier ways to do it is we have a patient with full dentition. We prep all the teeth and we put them in interim prosthesis, whether it's 1 arch at a time or 2 arches. So we can incrementally increase their vertical just with an interim prosthesis. Then when we get the patient comfortable, then we use that vertical as our definitive prosthesis. When we have a patient with dental alveolar extrusion, this becomes a little bit more difficult. These are cases where we have to take the surgery. We have to anticipate how much we are going to remove versus the bone. So we have to understand how much is actually extruded, how much extrusion has been there. That will tell us how much we have to remove. Then we can go ahead and reestablish our vertical. Then we can use anything from overdentures or fixed prostheses. And one of the easier techniques, if you have teeth, and I use this a lot when we're doing bone grafting, is the smile transitions. Glidewell does a real nice job. If you have teeth on both sides, you can actually use this as a great interim prosthesis. What I like about it, it doesn't put any pressure on our grafts or our implants, and you can incrementally increase the patient very easily through the smile transition. So that's one case. Here's another bone graft case. So we can give the patient something very aesthetic and we don't have to put anything in removable. So again, it's not going to lead to any morbidity of our surgical procedure. So that's called smile transitions from Gladwell. So when we reestablish vertical dimension, one of the hardest patients is going to be with an all-on-X case. And why is that? Because a patient comes in like this. They have maybe a collapsed vertical, only a couple teeth. They've actually lost their vertical. They don't even know where their centric is. Now what we do is in one day, transform them into a vertical, and then hopefully they'll adapt into that, or sometimes we have to make a second PMMA prosthesis. So what is the issue when we're doing that? When we're using a CBCT scan and evaluating and increasing our vertical dimension. Usually we use a program like Exocad here, where you have a virtual articulator. You take a dual scan. They're able to superimpose the upper prosthesis, the lower prosthesis over top of it. And then you can go into the software, and here's just one example of it, where you can increase the bite as much as you want. So it increases VDO, in this example, 2 millimeters. So what is the problem with that? The only issue I have with these software programs is they don't use the right ratio. So yes, they'll increase the posterior 2 millimeters, they'll increase the anterior 2 millimeters, but the 2 to 2 ratio isn't the correct anterior posterior ratio. We know that the TMJ is the fulcrum, mandible is the lever, and if we increase the posterior just 1 millimeter, it's going to increase our anterior 2 millimeters. And if we have a semi-adjustable articulator, it's going to be 3 millimeters on the pin. That's called the 1-2-3 ratio. So these software programs do not take that into consideration. So why are we even talking about that? Why am I mentioning it? Because this happens. This is just a single arch, but here's a case where a doctor was trying to put the prosthesis in. They're occluding on the posterior, not in the anterior open bite, because the software opens them as a 2-to-2 ratio, not more nor the normal 1-to-2 ratio. So that is a problem. Now you can correct that. Yes, you can grind down the posterior teeth, but now that might impose on the restorative or the prosthetic space, and now you might end up with a prosthesis that fractures. Now, in the future, there is some really new, neat technology. One is this bite finder. This is artificial intelligence. So the artificial intelligence actually can take the upper and the lower jaw, and they take the TMJ and the arc of opening and closure in the consideration, and they make it more of a 1-to-2. So it simulates the bite, it evaluates wear facets. It's really interesting. I think that's probably the future. So in the future, we will have this artificial intelligence that will help us. Now that I've spoken for about 40 minutes and you are completely confused about vertical dimension, which most people are because it is a very confusing subject and there's really no right and wrong answers. However, I'm going to give you something to take back to your practice. And hopefully these are pearls that make sense, that will protect you, number one, and keep you from having an issue with a patient that could be catastrophic, especially in the legal field. Number one, no universal ideal technique to evaluate VDO. Ideally, pre-extraction records are the best, but we have to use all these other ones. So you want to use multiple techniques in evaluating a patient's vertical dimension. Before increasing vertical dimension, you have to determine if the patient is a candidate, not like this on the left, where most likely the lower arch was fabricated first, way too high, and most likely a too increased vertical dimension. Use this newer technology as CBCT scans and all these software programs, but you have to understand not every patient is a candidate. I gave you 3 examples: patients with significant parafunction, patients with dental alveolar extrusion, and then patients that you're just going to open it up because the implants are malpositioned. Know that when you do open someone like this, that there is a balance between function and aesthetics. Yes, maybe their vertical can withstand being open this much, but there is an aesthetic result. And sometimes it's very hard to balance the function and the aesthetics of a reestablishment of the vertical dimension. VDO is a fixed point. We know that we have the patient bite. It's very easy. It's teeth dependent or centric stop dependent. The hard one is VDR, and that is a range. The newer term is called a comfort zone. So basically, the VDR is a range because it's muscle dependent. It's dependent on how the patient is positioned in the chair, what time of day it is, where their head is it caught backwards or posterior or anterior. So there is a lot, patients under a lot of stress. So there is a lot of variables with that. Increasing VDO, gradual, what should we do? Can we go right from taking someone's teeth out to a PMMA to a definitive prosthesis? Or what some people do now is go right from the natural teeth to the definitive prosthesis. I believe that's a little bit dangerous in most cases. So you should incrementally increase it. If you look at a patient like this, and let's say it's a 4 millimeter increase, it's very easy to make one PMMA, increase it a couple millimeters, make a second one if you want to open even more, and then go to the final. This way the patient can adapt slowly. If you look at incremental versus single step increases, there is some risk. And I always evaluate the risk versus the benefit of doing a particular procedure. So if we look, what is the risk? Well, if we open this patient too much, we can have TMJ issues, muscle issues, occlusal disharmony, aesthetic issues. And it is very, very difficult to go backwards. So it's a lot easier for patients to adapt. We know one thing, patients adapt very fast when you have natural teeth because of proprioception. If they have implants, we know it's very, very slow. So you have to be very, very careful. So my belief is incrementally is a lot safer. It decreases your morbidity. And again, evaluate the risk versus the benefit of it. It's not a big deal to make 2 PMMA prostheses, especially in some of these cases where the patients are really overclosed. Put that in your treatment plan. You can build that in right away, knowing that it is most likely going to happen. So this adaptation period, again, understand natural teeth, it's weeks. Implants can be months to possibly even years. But when we look at doing it too fast, remember, a lot of the TMJ symptoms that patients have, myositis, are subjective. And when they're subjective, that becomes very difficult. So patients can leave the practice, go to someone else. You don't want someone else Monday morning quarterbacking you. Neil, I made it with 2 minutes to spare.
You know, Randy, I don't know how you do it. You put together these lectures that cover a specific topic better than I've ever heard it covered before. Really fantastic job. And we have, as you know, a very, very intelligent group of attendees, and they've got some great questions. So let's get through as many as we possibly can. Okay.
Okay.
You started talking about these Willis facial measurements, like facial thirds, things like that. When you're taking those measurements, are we talking about having the patient at rest or to have the patient at MIP?
Some are at MIP, or I'm sorry, some are at rest. Most are vertical dimension of occlusion. So when we're looking at facial VDO, it all depends. There's so many of them, but like the Willis is VDO, but there are some that I highlight in the textbook that are at rest. So facial measurements. Go ahead. I'm sorry.
Well, I'm just saying that are we changing the patient's rest position, or does that?
So it's interesting, Neil. When you and I went to dental school, we were taught that rest position, you have to calculate it, and basically it's a point. It's a static point. And that's kind of been disproven over the years, where now it's called a zone. The problem why the problem that ensues is when you're looking at a zone, it's a comfort zone. However, how do you determine that? As I said, it depends on the time of day, the patient's stress level, the patient's position in the chair, their head position. So there's so many variables, and that's why I think it's very dangerous for some of these cases. And I see it in the medical legal arena where people just open these verticals way too fast. And, when you get TMJ muscle related complications, you don't cure those in a day. Sometimes they're forever. They can be irreversible, especially with the TMJ. So that's why the rest position is very difficult to determine. And that's why you have to use more than one method. So facial measurements is just one of many that you can use.
Okay. Here's an interesting question. Does increased VDO ever occur for reasons other than prosthetic alteration? I mean, is there some growth process perhaps or occlusal changes that can result in an increased VDO?
So meaning does a patient can later in life, their vertical dimension actually increase because
Right.
of facial growth? Is that
Yeah.
actually there's two schools of thought on that. Some people say it does change. Okay, you get passive eruption of the teeth and it can change. Other people say that it doesn't. One of my attendings when I was in my residency, he actually tattooed himself and he measured himself over a long period and it never changed. So that's just one example. But again, there's really no good studies on that. I think if vertical would change, okay, most likely it's going to change, decrease, not
Right.
increase. Yeah.
Right. I mean, there could be some growth dysfunction that causes the jaws to grow, I
Yeah,
would
well,
imagine.
I mean, especially in males because they go through the growth spurt later and longer later than females. But you can have, especially premaxilla growth into the 20s and 30s, so it can happen, especially
Okay.
passive eruption.
Okay. All right. Here's a question about increasing the vertical dimension. If let's say the patient has a freeway space that's 7 millimeters, is it safe to increase the vertical as long as you stay within that 3 to 4 normal range? Can you feel pretty safe increasing the vertical dimension within that area?
That's a very good question. And our thought process is if they have a 7 millimeter freeway space, we open them 4 millimeters because they should have a 3 to 4 millimeter, but that
Right.
doesn't always happen. The problem with opening someone 3, 4, 5 millimeters is the aesthetics of it and function. So patients might be at that vertical for a long period of time. They might have parafunction. So they're very adapted into that vertical dimension. You open them up, and especially where it's very drastic. And I mean, I see cases all the time where I'm there like, it's amazing that the body does adapt, but in some cases it doesn't. And I wouldn't want to be involved in one of those cases where it doesn't
Right.
adapt. It's a
Right.
problem.
You're going to be remaking that prosthesis to the original vertical.
Yes,
Because
exactly. Or someone else is going to be remaking it and you're going to be paying for it. So,
right.
mhm.
Yeah, and right along this same topic. So if you have an edentulous patient, you're making complete dentures. They've got an atrophic ridge. Uh, the wax rims don't even stay in place. I mean, are you going to be increasing vertical here? I mean, I guess for the health of the jaw, you might have to.
Well, I mean, there's a lot of variables when you're talking a significant atrophied patient. I mean, in those type of patients, we're looking to make a nutricentric denture where basically everything is even and the muscles are holding it in. But just opening them as much as you can isn't because think if their lower facial height is compromised, their lower ridge is compromised, and you give them a denture that is very, very thick. Now that's a higher lever arm, and you're going to have a bigger moment force, which is going to torque it back and forth. So it can be compromising.
Exactly. Exactly. Okay. What about with removable partial denture? Can we raise vertical? I mean, I guess it depends how many teeth are involved, right?
Yeah. So I showed that example where you can use an existing partial just to incrementally increase the patient's vertical. But in a lot of those cases, to actually increase someone's vertical, you're going to have to do a complete full arch rehabilitation, at least one arch. And in those cases, like the case that I showed, it opened the vertical to where they had no anterior guidance then. So now you have a functional problem and you have an aesthetic issue. So my thought is, can you open them a little bit with an existing vertical and maintain that partial? Possibly. You're most likely looking at refabricating a partial at that new existing vertical dimension.
Got it. Got it. Okay, here's a great one of those things where autocorrect makes a funny makes
Okay.
your words funny. So the question is, do you always have to do a Facebook when increasing the vertical? And I'm pretty sure she meant Facebook, right?
Facebook. To be honest with you, most people don't. Okay. It all depends on what type of articulator. Neil, you and I were taught on semi-adjustable articulators. Then, yes, you need a Facebook. The newer technology doesn't use Facebos. They use these computer programs. And I showed you the Exocad. And the way they do it is they just open up anterior and posterior the same amount. So a Facebook is not going to matter anyway. So the correct answer is you should use a semi-adjustable articulator if you're changing vertical. Yes, you should have a Facebook.
Right, right. I mean, my understanding is that that'll give you the actual hinge of occlusion, right, where that comes from, and then you have a little more freedom to correctly change it.
And you have a baseline. So you always have a baseline of where the vertical was.
Okay. This is another question. So you're trying to incrementally increase VDO as you suggested. What's a good interval? I mean, should you start with just like 2 millimeters at a time, or is it
Well,
less than?
well, so a good way, another way to look at it is let's look at the patient. So let's look at that patient with mastoid hypertrophy that has had significant attrition that they actually need opened a little bit. Those are patients that I would do over months and just maybe with a little composite or maybe with a occlusal guard and just incrementally do those by less than a half a millimeter. If you have a patient that is more elderly and really collapsed and you have to open them 5 millimeters, my example that I gave in the lecture was you open it up 2 millimeters, then another 2 or 3 with a second PMMA. I like just making another PMMA because it's easy for the lab to do, number one. Number two, then that patient can get very adapted to it and very comfortable. And then all you have to do is duplicate that PMMA. So it's very, very easy. So I guess the easiest answer to that, it all depends on the patient and how much. Incrementally on any patient that has TMJ issues already or could possibly have TMJ issues or muscle issues.
Okay. Here's a question about a technique that I'm not familiar with. Is the Shimbashi measurement a good way to measure vertical dimension of occlusion?
So the Shimbashi method is a method where you bite together and you have the patient bite together and the anterior, the CEJ to CEJ should be 18 to 19 millimeters. Orthodontists use that a lot. It's in the ortho literature. I've really never used that ever, but I know about it. The studies do show it's relatively accurate, similar to the facial measurements. So it is. So basically, you have the patient occlude, measure, CEJ to CEJ, maxilla and mandible should be 18, 19 millimeters.
Okay, here's an interesting question. I have a patient with perfect occlusion, but down through the years, she has clenched enough that she has splayed her anteriors out. Now the open embrasures are driving her crazy. What what are answers other than ortho or raising the posterior bite? No, so I guess he's saying that she's overclosed now, But if she
Yeah.
has splayed anterior, she probably doesn't have perfect occlusion anyway,
Oh,
right?
yeah. Well, if you have splayed anterior teeth, that might be the mandibular teeth. I would look at the mandibular teeth first because you might have had super eruption of the lower anterior teeth and the alveolus. So the vertical dimension, you look at the posterior wear. Is there any wear? Most likely in those type of patients, they don't have any posterior wear. So their vertical dimension is the same. The only reason it's splayed is because the anterior teeth have super erupted and it's pushed out the maxillary anterior. That patient needs to be evaluated, ideally ortho. Okay. Just by opening the patient's bite, that could, if you do that with someone with huge masseters, you know, with parafunction, they're going to grind right back to where they were. So you have to be very careful of it. So you need to go through all those tests that I showed or
Right.
evaluations to
I mean,
assess it.
can those anterior teeth splay without the VD being closed?
Yeah, that's what I'm saying. So
Yeah.
what ends up happening is the posterior teeth maintain the vertical, and what happens is the anterior teeth super erupt. That's called dentalveolar extrusion. Because they extrude, what they're doing is they're hitting higher lingual on the, or they might not have even hit the maxillary anterior teeth. Now they're hitting and they're splaying the maxillary anterior teeth
Okay.
out. So
Gotcha.
just what you said, Neil, yeah, their vertical might not have ever changed. So you have to be very careful because if you try to do like a full mouth rehab on that case and the patient can't adapt to being open, I mean that gets into a very complicated situation.
Great, great. Got a question here about the images you showed of digital articulation. Can you recommend a program? I know we look at these things every week at the lab, looking for a good program for digital articulation. Any recommendations?
I mean, we use Exicad, which is probably one of the most
Yeah.
common out there. But just remember, so everyone understands, virtual articulators are more for show than anything, okay? Because they're not giving us the hinge axis, they're not giving us the arc of opening, they're not taking the actual TMJ into consideration because we don't have that information. So you have to be careful with that.
Right, right. And the last question, increasing vertical dimension. I mean, this is a process of muscle adaptation. There's no bone adaptation, right? The bone is not growing into this position.
No, it's basically muscle. However, if we go back to what can happen if you increase someone who cannot adapt to it, then you'll have bony changes because the teeth have been shown to actually intrude. So you can actually intrude teeth, change the bone level in what some of these people with really bad very strong masseter muscles.
Wow.
So
Is that
if you
is that a
look at
technique for increasing periodontal support?
Yeah, true, true. It's very hard to do if you think about
Yeah.
if you know anything about extruding or intruding teeth. It's very hard to intrude teeth. But the
It's very hard to
master
do it when you want to do it. It's very easy to
exactly
do it if you don't want to
they
do
don't want to do. And
it.
that's
Right.
why if you look at that one X-ray I showed, the Panorex, when you have anagonial notching, that means that's the insertion of the masseter muscle. If that's worn out the angle of the mandible, you know you have a problem with parafunction and excessive bite force. So just be cautious on those.
Well, thank you, Randy, once again for
Okay.
a fantastic lecture. We appreciate it. Thanks to the panel and
Okay.
thanks everyone for joining us. Appreciate it. We're going to be off for the next 2 weeks. We've got the implant symposium and then the aligner symposium, but we'll be back in 3 weeks, and our guest speaker will be Dr. Christopher Resnik, and he's going to give us a great lecture on the restorative options for full arch implant restorations. So thanks again to everyone, and thanks to the panel. And we'll see you back in about 3 weeks. Take care, everybody.
Thank you. Thank
Great.
you.
Thanks.
Yeah,
Thanks,
thank
Randy.
you.
Great job.
Okay.